Sir, we are live now. With all your permission, I'm starting this session. A very good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Vilas M. Pandurangi, sir. And let me share some of the achievement of this sir. Sir has done MD, DM in Cardiology, FRCP, Chief Department of Cardiac Electrophysiology and Pacing, Madras Medical Mission Hospital, Chennai. Today, sir is going to discuss on a topic, prescription of GDMT, real world challenges. Before starting this topic, let me tell you overview of the topic. GDMT for cardiovascular condition like heart failure in the real world can be challenging due to the several factors, including patient adherence, complex medication regimes, potential drugs interactions, and individual treatment responses. Additionally, access to the certain advanced therapies and the cost of the medication may be changed and medication may hinder GDMT implementation. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Stage is yours. You may proceed from there.
Thank you, Mr. Faraz. Hello, everyone. Good evening. It's a privilege and an honor to discuss with you all in today's evening about some important topic, that is the real world challenges when you would like to prescribe the guideline directed medical therapy in the way the guidelines recommend. Thank you, Faraz, and thank you, Ankana, for coordinating with me. And it's a pleasure to be involved with activities of IJCP. So let's start discussing now what are the challenges when it comes to prescribing the GDMT. It is a very well-established fact that if we follow what the guidelines have recommended, the medications, the dosages, and the follow-up to reduce the mortality, to reduce hospitalization rates, and to increase the quality of life in patients with heart failure with reduced ejection fraction, who have, if not treated properly, very bad prognosis and a very poor quality of life. There has been a mounting evidence that we should start the guideline-directed medical therapy as early as possible because that is very critical to achieve the desired goals. We should not withdraw the medications if the patient is improving, what we call a heart failure with improved ejection fraction patients. We should continue to use those drugs and to increase the dose to the target levels as far as it's possible. However, the real world data gives a different picture. It is becoming very well understood that the guideline directed medical therapy is indeed a huge challenge for every stakeholders, for the clinicians, for the health systems, the government, and from the patient's perspective, also there are issues. One of them is the poor adherence. Guidelines recommend 4 major class of drugs to treat our heart failure patients with reduced ejection fraction to improve the survival and improve the quality of life. Those 4 major group of drugs are ARNI or ACE inhibitors or ARBs. Another class is the beta blockers. Another class is the mineral receptor antagonists. Another one is the SGLT2 inhibitors. Guidelines also recommend some of the drugs which could be administered on an individualized basis for reducing the congestion, avoiding anemia in certain arrhythmias, tachycardias, resistant heart failure, even after using these four major class of drugs. And recently, Vericiguat is shown to be giving some positive results, especially in those patients who have worsening symptoms despite standard therapy. This all sounds good. It also appears that we should be giving all of them, escalate the dose, and if it is required, add some more drugs. But what is missing in the guidelines is how exactly we start, which are the medications to start, which one of the medications the dose should be increased first, and within what period of time we should be achieving the target doses. There has not been a specific recommendation from any one of the heart failure societies who are recommended or who had answered these questions. Hence, we fall upon some of the experts because of their participation in huge trials, registries, and their huge experience. We follow their advice. For example, these are the four major publishers on heart failure therapy. They are the researchers, clinical researchers in heart failure therapy. For example, McMurray. Everyone knows McMurray, and he has recommended that we should be achieving the guideline-directed medical therapy with respect to the target doses within 4 weeks. And he recommends upfront initiation of the beta blockers and SGLT2 as a step one, followed by ARNI within 2 weeks, and MRAs in 2 more weeks, etc. So essentially, start as early as all the class of drugs, all the four major classes of the drug, and achieve within 4 weeks. Another expert, Miller, he tries to classify his patients into 3 groups: one with the volume overload, another one without the volume load but the hypertension as the major driving factor for the heart failure or high heart rate. So there are at least some 3 groups. That's called cluster scheme, and he recommends, depending upon what kind of a cluster the patient belongs to. Volume overload, use diuretics, SGLT. If there's hypertension, we use mainly ARNI, MRAs to achieve the target dose. Heart rate, if that is the issue, beta blockers and sinus node inhibitors. Similarly, the other 2 experts are recommending their own way of achieving the GDMT over a period of 42 days. So there is no uniformity, but in general, there is a certain common recommendation, and that is to start as early as possible, number one, as many as possible, try to increase the dose as fast as possible, and to reach the target dose as early as possible. These are the recommendations, but let us discuss now why it is so very difficult to follow the guidelines or the recommendations. To make things simple, guidelines have also recommended to look at certain clinical parameters where it is possible to at least start off with one of those 4 drugs and escalate the dose. For example, if you consider the heart rate, you can classify into the rates less than 60, 70, or more than 70, and then look at their blood pressure, whether they are borderline hypertension or they have maintained good perfusing pressures. Look at the rhythm, sinus or atrial fibrillation. Look at their kidney profile, and also whether there is an element of congestion. Based on that, you could have almost 11 phenotypes, wherein, for example, one of the phenotypes where it is possible to start off all the classes of the drugs as early as possible and escalate the dose. And that is this group of patients without AF, pressures being good, more than 100, heart rate about 60, 70, and then there is no kidney dysfunction. But such patients in our population, I do not think, heart failure patients, I do not think there are more than 50%. But if we have this kind of a patient, this is the ideal group of patients where we can escalate the doses of all the 4 classes of medications. And probably this is the only group wherein we can actually prescribe the guideline-directed medical therapy in the way it is prescribed. Yes, physician can prescribe, but what happens to the hemodynamics of the patient? Can he afford all these medications? Is there a physician who knows all these medications and how to be administered? These are the challenges. Even if you have started the medications, it is not very often that the medications are continued in the way the guidelines recommend. It's not only in our country. For example, even in some of the most well-developed countries with strong economies where the healthcare is taken care by the government or the insurance. If you look at the data here, which is published recently, more than 270,000 patients data when they looked at, well, 80 to 90% of the patients would have been on most of the drugs recommended in the guidelines to begin with. But what happens over a period of time in these heart failure patients? If you take any class of the drugs, not more than 25% of that particular drug has been continued or taken at an appropriate dose. So this is the status even in some of the most well-developed countries. So there must be some strong reasons why they are also not able to achieve the target doses in the majority of their patients. One more slide I'm showing here. When it comes to trials, well, you have almost 80 to 90% of the patients have been given all the 4 classes of the drugs. May not be all of them in the target doses, but at least 90% of the patients. So when it is in the trial itself is not 100%. And when you're looking at the registries, it is much worse. 30 to 50% of the patients only in the registries have been prescribed all the 4 classes of the drugs, and only 30 to 50% of the patients could tolerate or they were on the targeted doses. Some of the common causes are the drug effects themselves. For example, administering the drugs, not necessarily the maximally tolerated drugs, may cause acute kidney injury because of the direct renal injury or hypoperfusion. There can occur hyperkalemia. There can occur symptomatic hypotension. Patient may not be able to adhere to the advice, and patient may not be able to afford the medications, or even the healthcare facility doesn't have enough of physicians with adequate knowledge to prescribe and follow up these patients. So these are some of the major items which will have an impact on the GDMT administration. There are some solutions here. For example, if you're looking at the acute kidney injury, most often it is because of the ACE inhibitors, ARBs or ARNIs. So you may try to reduce, don't simply stop it unless it is a severe kidney injury. Try to reduce the dose of the ACE inhibitors, ARBs. Maybe the patient is being given more than necessary diuretic dose. Try to reduce the diuretic dose. Hyperkalemia, well, if there is a potassium supplementation, you can take it off. And again, you can reduce the ACE-RBs, or you may give some potassium binders. Symptomatic hypertension, again, try to reduce those medications which may cause lower blood pressure. For example, if there is a combination of an antihypertensive with all these 4 drugs, make sure that you are able to reduce or withdraw some of the drugs. Adherence is an important aspect. Patient education is important, and there are certain things which are outside the scope of the physician, but it becomes the responsibility of the society and the government to see to it that most of the patients can receive the medications. So this chart, I think it is going to emphasize what I've been telling. There are medical socio-demographic characteristics in the form of advanced age, renal dysfunction, and really fragile patients, etc. Maybe in them you may not be able to prescribe the medications to the targeted dose, and the drug adherence, if it is possible, some education, encourage the patients, the relatives, to make sure that the patient adheres to the medications and the lifestyle. It should be possible for the government to invest more funds in the healthcare delivery. And apart from that, the education of the physicians themselves. Education of the healthcare professionals, I think, is very important. I think this particular talk by the IJCP, I think it is directed towards bringing out the issues that are related with the administration of the drugs in the heart failure therapy. So education is important. Maybe we should be looking at telemedicine, for example, which includes the monitoring of the health of your patient by some wearable devices, some implantable devices, or virtual consultations might also help in following up the patients and insisting on the patient's adherence. So finally, I would like to say that the patient needs to be empowered from the point of view of affordability. He should be made to understand that the adhering to the regimen is so very important. Physicians should be aware about the guideline-directed medical therapy. He should have always a list with him and to check whether all those medications have been considered for your patient. Dose adjustments need to be done at least in the initial stages of 3 to 6 months, so that if there are any adverse effects, they are taken care. And if there's an opportunity to increase the dose, the dose can be escalated. And in one of those complex cases where there are multiple comorbidities, like a heart failure patient with severe diabetes or severe kidney disease, heart failure patients where the arrhythmia could be the major issue, heart failure with some neurological issues, I think in those situations, one should not hesitate to have a multidisciplinary approach. And in this era, remote monitoring over the wearable devices, implantable devices, and the virtual consult could also help to overcome the challenges that are that are that we face when it comes to the guideline directed medical therapy. Thank you. I'm going to be here to receive any questions the audience has.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants who have joined these questions. Sir, I can see, sir, we have received some question from the participant end. If you allow, with all your permission, shall we take these questions?
You should, please.
Thank you so much, sir, for allowing. Sir, I can see first question from Dr. Agarwal. He's asking, what are the challenges and strategies for the implementing GDMT in the heart failure with reduced ejection fraction?
Yeah. So the whole talk was about all that. First of all, let's start with the socioeconomic issues. The heart failure patients with reduced ejection fraction is supposedly to take at least 4 major classes of the drugs, and the cost becomes a factor. So not many people could afford. Second, the drugs are supposedly to be exerting their maximum benefit when they are prescribed at the target doses. The target doses is the dose at which the maximum benefit is noted. When you are escalating a particular drug, which you have started off to reach that particular target dose, many patients may not tolerate that. There can be issues of hypertension. There can be issue about worsening of kidney functions. Maybe there's not going to be an adherence. So there are multiple reasons why not all of our patients with heart failure with reduced ejection fraction will receive the guideline directed medical therapy at the recommended dose.
Thank you so much, sir, for explaining your views on this question, sir. I hope that Dr. Agarwal has received his answer. Moving forward, sir, I can see another question from Dr. Subramanyam. He's asking, what are the predictors of underutilization of medical therapy in the patient undergoing endovascular revascularization for peripheral artery disease?
Yeah. So that's the out of the scope of the discussion. But well, the predictors are again the same thing. The endovascular interventions for the peripheral artery disease, you see, that is a kind of a niche area. Why not many people will receive? I think the major reason is the lack of the experts spread across the country. I think only few major cities can provide this kind of a service, and they are expensive, and it requires a lot of expertise. So lack of facility and expertise, these are the reasons. These are probably the reasons for not, these are the reasons for not many patients receiving the endovascular therapy for peripheral artery disease, especially the diabetic patients with peripheral artery disease. They needed to be treated quite vigorously to save the so-called diabetic foot and such complications. That's major morbidity for long-standing diabetic patients. Yes.
Thank you so much, sir, for sharing your insights on this question, sir. As I can see, sir, there is no more question, but Dr. Shruti Singhania is writing important topic. Thank you so much, sir, for covering this. And Shruti has written this compliment from our side, sir. I hope that the doubts are clear, as so that we haven't received any questions till now. If we receive in future, sir, we can collaborate with you and just get the answer through their email ID, sir. Thank you so much once again, sir, for giving your valuable time. Sir, as there is no more questions, sir, with all your permission, shall we conclude this session?
Yeah. So for us, thank you very, very much. And all the members in the IJCP. And, it was a privilege for me to come on this platform and express my few of my views.
Sir, all the pleasure is mine, sir, and thank you so much. All the credit goes to doctors like you, sir. Like being busy, also you have taken out your important schedule for this session, sir. I hope that this session will be impactful for all the practitioners, general practitioner, as well as the general public who is receiving a correct knowledge from experts, sir. And I hope to see you again in future with different topics, sir. Till then, take care of yourself. Good night. We are closing here, sir.
Thank you so
Thank you.
much.